Hi, everybody. I'm Dr. Kirsten Sumner. I am a hand surgeon in the East Valley location. My office is in Mesa, and I also do an outreach in Scottsdale. So it's glad to be here this evening. I'm here to talk about some common injuries of the hand and wrist, but first I just want to tell you a little bit about myself. So I am new to the Phoenix area. I moved from the East Coast, originally from New York, but did all my training up and down kind of the East Coast. Did my medical school at Georgetown in Washington, D.C., my residency orthopedic surgery at Geisinger, which is in Pennsylvania, and then I was in Miami, Florida for my hand fellowship. And then I came out here, and now I'm in Phoenix, getting to know what the desert is like, although lately it's been quite rainy, which is interesting. But I'm happy to be here, and hopefully I'll maybe get to see you in my clinic. Obviously, if you're seeing me in my clinic, it's because you have a problem, and I don't want that for you. But if you do, I'm happy to see you and try to help you get better. But today we're going to talk about some of the common injuries that I've been seeing lately. So just a little bit overview on the topics I have here are distal radius fractures, fifth metacarpal neck fractures, or boxer's fracture, you might hear it called, and finger sprains, because these things kind of commonly occur on a daily basis and are things that I see regularly that have some pretty known treatment options. So wanted to go over them with you today. So let's talk about bones. A couple of the topics I'm talking about today have to do with broken bones. So first off, I want to talk about broken equals fractured. So you might hear this commonly, I broke a bone, but I didn't fracture it. Or I fractured a bone, but I didn't break it. Or I broke this bone, but I fractured that bone. Just of note, a broken bone is a fractured bone. It means the same thing. It means that your bone, which was once whole, now has an injury to it. Whether or not it's displaced is kind of something that people will look into further. So if they have a broken bone, they might think, oh yeah, it just broke, but it's okay. And if it's fractured, that means it broke and it really moved out of place. They're the same thing, it's just the extent of the injury. So I just circled some evidence there of a broken bone. These are the two bones I'm going to be talking about today, the distal radius and the fifth metacarpal. And at those locations that are circled are some breaks in those bones, or fractures, if you'd like. So healing. When we break a bone, our body starts the healing process as soon as the break occurs, which is pretty amazing. Over time, as the bone heals and becomes more solid, your pain will improve, which is a good sign. As pain continues to improve, it's showing your body, it's a sign to you that you are healing this as you should. In general, I like to always tell my patients when they come in with a broken bone that bones take about 3 months to heal. Now that does not mean that when you first come into me, that severe pain that you're experiencing, because this just happened, is going to occur for 3 months. It just means on a time frame, just be realistic. You're not gonna have a broken bone today and in 2 weeks be, playing basketball. It's gonna take a little bit of time. But like I said, the bone healing process starts right away, and as time goes on, you'll feel better and better and better by the time it's fully healed at about that 3-month mark. Now, some bones are a little bit quicker, some bones take longer, but that's just an approximation. Some common things your doctor might talk to you about. Malunion. Malunion is when the bone heals, but it heals in a position that's abnormal compared to your pre-injury position. We accept some degree of malunion in all of our bones, right? Because it's hard to get our bone back to exactly the position it was before it broke. So this is very common. Sometimes with surgery, we'll recommend actually improving the position of the bone to avoid a bad malunion from occurring. Non-union means your bone doesn't heal. And luckily for me, as a hand and wrist surgeon, non-unions rarely occur in the hand and wrist. Our hands and wrist areas, they like to heal very, very well. So uncommon, but can occur. And non-union is something that has to do with your biology and kind of the stability of the fracture that occurred. So, but that in general is something that's when a bone does not heal, okay? So let's talk about distal radius fractures. So for one, what is your radius? Your radius is a bone in your forearm. I kind of showed a picture there of your radius and your ulna because you have two bones in your forearm. And the radius bone is pointed out there. And distal means the location at the end of the bone. And in this case, that means far away from the elbow or by the wrist. So I put an arrow there showing the distal end of the radius, which, and then a location with a line on that X-ray to show about where that broken bone is, okay? Distal radius fractures, very common, hundreds of thousands in the USA annually. And about 50-50 occur in two different types of populations. So there's a younger population that, or I mean, all people can get this from trauma, but tends to kind of occur in a younger population from a sports or a high energy injury like a motor vehicle collision. And then there's an older population, which is typically females more than males, and it's from a low energy injury, which is typically from a fall. So you trip on, something on the ground, whatever, you fall out into your arm and you break your wrist. So those are two different types of populations that we're talking about that commonly get this break. What to expect? Well, initially, you're probably gonna go to an emergency room, especially if you're in a motor vehicle collision, or you might go to urgent care, or you might show up in my office as your first initial evaluation. You'll get some X-rays of your wrist. Your wrist might be very swollen, painful. We'll get some X-rays, and if it shows that you have a distal radius fracture, it's the topic that I'm talking about, you might get a possible reduction. Now, that's more likely to occur in an emergency room setting than a clinic setting. And a reduction means if your bone is really out of place, we might try to put it back into a better position to A, help your pain and your swelling, but B, also put it into a better position that you might help with deciding what your treatment should be, whether it be surgery or not surgery. You'll get into a splint similar to on the screen that you'll see, that's called a sugar tong splint. Usually we'll mobilize the wrist and the elbow for initial help with the swelling and the stability of the fracture. And then you'll follow up in an orthopedic clinic within typically about a week to get further evaluation and kind of discuss treatment and go from there. So when you come into clinic, the big thing is you have a broken bone. I wrote to immobilize or to surgerize, okay? So when you break a bone, you have two types of treatment pathways. Either we're going to try to immobilize or treat it non-operatively, or bring you to surgery to try to fix the position and provide some stability via a surgical approach. Who gets surgery and who doesn't get surgery? Well, this is a very big combined decision-making process between the surgeon and the patient. It is not a 100% all of these get surgery or 100% all of these are non-op. They are actually really important specific factors that go into this decision-making process. So first off, your age and your occupation, right? So someone that is a 20-year-old heavy male laborer or female laborer who is going to be doing a lot of lifting on a daily basis is going to need different demands and treatment than someone that is maybe older and retired and maybe plays cards instead of having to pick up big cement blocks on a daily basis. So our age, our occupation, our physical demands, they really go into play into our decision making. Our overall health, right? If we're really unhealthy, and surgery is something that's really risky for us, we might try to do non-operative treatment more than doing surgery. Personal opinions, I have patients that come in and say, I don't want surgery if at all possible, no way, no how. I've got other patients that say, if surgery is going to get me as close to perfect as possible, I want the surgery, right? So everyone's different. Your physical exam, obviously an open injury means that when your bone broke, it cut your skin. That is something that is going to get you a surgery. So that's something you're more likely to see in an emergency room, but that's also something that's going to bring you more towards surgery. Your neurovascular examination, right? So this means that when we check your exam to see if you have any numbness, any tingling, it's making sure your nerves are working. If we have concerns, we might recommend surgery, such as if someone has really bad numbness and tingling, that's a sign that the swelling is putting pressure on their nerve and is causing a lot of irritation, and that's something we might try to convince you that surgery is the better option for you to try to get that pressure off the nerve. Versus someone that has a normal exam that has pain, but their numbness, they don't have any numbness, tingling, sensations intact. The characteristics of the broken bone. So this is mostly, evaluated by your X-rays that you're gonna get. We're looking at a few things. Does the break at the end of the bone go into the joint, into the wrist joint? And if it does, has the wrist joint moved at all? Is the overall alignment good? Is it straight? Is the bone obviously crooked and really off? Those are things that we're looking at. When we look at it, do we think this is going to be stable? So is the position okay, but do we think it's going to move if we treat it without surgery? And if it moves, it's going to be in a bad position for you? Well, then we might discuss more recommending surgery versus not. Versus if it looks really stable, it's broken, but it's stayed in a good position, this fracture pattern looks like, these heal really well without surgery, then are obviously going to go down that route. So a lot of things come into play when we talk about surgery or no surgery for this type of injury. Just some images, kind of a this versus that. So the X-rays on the left are showing you both of these wrists images are broken. So that's an AP X-ray, so looking at it like this, versus a lateral X-ray, which is looking at it like this, okay? And when we look at those images, we use those two, and plus usually an oblique view, which I did not involve because we don't need to go there. But we look at those two images and we kind of look at the overall position. You can see the X-rays on the left, really, the broken bone didn't really move. So it broke, but it's in very good alignment. You can barely even tell that it broke. And you might not even notice it if you don't look at X-rays like this on a regular basis. And even if you do, you might miss it, right? So that kind of a break is kind of an obvious, we don't need to treat this with surgery because it's in a good position, it's very stable. If this person heals like this, they'll have a great outcome. The person on the right, you can kind of see these X-rays look a little bit abnormal. Now you might not be able to tell that because you don't look at these X-rays all the time, and that's fine. But the position of the wrist on these two X-rays is very abnormal and not ideal for a good healing position for going forward for your function. So X-rays on the right are kind of more of something that if I saw on a patient, obviously taking into all those other accounts of their, age, functional demands, and all this other things, but this type of an X-ray, I'm more likely to try to push you more towards surgery as your best outcome, not because I want to force surgery on you, but because I know based on your goals, you'll probably do a lot better with surgery and getting that bone into a better position. There's obviously some level in between of those images, and when we do look at these X-rays, I'm just going to go back, we are looking at specific parameters on both those images. We're measuring angles, we're looking at how the joint is aligned, we're looking at the position, and that's easier to go over with you in person than it is to show you in this general setting, but there's a whole lot of things that we're looking at on these X-rays to kind of come to a decision-making, final decision with you based on what would give you the best outcome. Non-operative treatment, so for this type of a break, what are you looking at if you wind up going down the non-operative route? Well, you're looking at immobilization. We need to give some support to your wrist as it heals, and that's usually in a cast and or a brace for 6 to 8 weeks. Now, typically, if you first come in, if you break your bone and you see me the next day, we might start with a splint at first because your swelling is going to go up, and we don't want to put you in a cast and confine you too quickly because then you might have a lot of pain. So initially, you'll be in a splint for the first 1 to 2 weeks depending on your swelling, and then you'll get a cast. And I like to cast people for about 4 weeks at a time and no longer because casts get very smelly and get very dirty, and no one likes a cast on for that long, for much longer. So 4 weeks is about the limit I'll put a single cast on. Then you'll come back, we can get new images and go from there as to whether we put you back into a cast or a brace depending on your comfort, the X-rays on how you're healing, and overall how you feel more comfortable with whether you'd prefer a cast or a brace at that point. But you're looking at immobilization pretty much 24/7 for about 8 weeks. In the whole time, you should be elevating your arm. You will get swollen every time you break a bone. You will get swelling. And elevation helps to improve your swelling. And improving your swelling will help improve your pain. So all of this goes towards elevation is good for you, for your comfort. It helps you with your healing process, but also with your comfort and feeling better sooner in terms of the pain that you're experiencing. In addition, when you break your wrist, I like to tell people you didn't break your fingers, okay? So we want you moving your fingers right away. This is so important. I cannot explain to you how important it is to move your fingers when you break your wrist, because they are not broken, but they'll get stiff so quick. So if you break your wrist and you just keep your fingers straight all the time because you're afraid to move them because it's gonna hurt, you're gonna come to me and you're gonna have really stiff fingers, and instead of just rehabbing your wrist after it's broken, we're rehabbing your fingers, which are actually a lot harder to rehab than your wrist is. So moving those fingers is really, really important right off the bat, no matter you have surgery or no surgery, very important. At about that 8-week mark, for non-operative treatment, we'll start working on wrist range of motion, and we'll start gradually strengthening and getting you up to about full, ready to get back to full duty at about that 3-month mark. So as your bone's healing, the ideal situation is that your motion and your strength is already coming back and on the way to getting you out the door and getting better. Operative treatment. So if your surgeon if you do come to this decision to have surgery, your surgeon recommends it, and based on everything that we talked about, you are a surgical candidate. There are different things that you can have surgery, very many ways to fix this bone. First off, when you do operative treatment, there's closed or open reduction. That is just whether or not your surgeon has to make an incision on your skin to put the bone back into place. Now, very commonly, this type of injury is treated with an open reduction, which means an incision, and with a plate fixation, which is kind of those images with the plate and screws there. That's a very common way to treat this injury, probably the most common way that we treat this injury, but it's not the only way. So your surgeon, based on your fracture pattern, might recommend putting pins in it, like that picture that I also have up there. You might have such a bad injury to your wrist that you actually need a plate that goes all the way across your wrist and holds you straight until the wrist heals, and then you take it out. There's many different ways to treat broken distal radius, but I will say that the picture with the plate and screws is the most common way to do it nowadays, and is a very good way and very successful with making this bone with helping your bone heal and also getting in a good position for you to have the best outcome possible. So more than likely, that is what your wrist will look like after surgery. Post-op, the good thing about surgery is that the bone is starting to heal, but you've got the stability from the plate and screws or the pins or whatever you've got for fixation that we can get you moving a lot sooner, which is a really big benefit of having surgery. So initially for my patients, and most patients, you're going to be immobilized for about 2 weeks after the surgery in a splint. Main reason for this is let's get the soft tissues to heal. We want your incision to heal. We don't want infection. We just want to let things calm down, because after all, surgery I consider is an insult to your body, right? We're doing things to your body that it wasn't ready for. So we want things to calm down. We want your swelling to improve. You want your incision to heal. We don't want you to have an infection or wound healing problem. So I immobilize you for 2 weeks, and then, but right up there again is finger range of motion right away. Like I said, non-operative or operative treatment, we're moving those fingers. At 2 weeks, we can start forearm rotation and gentle wrist range of motion. So we start doing palm up and palm down, because this type of motion, in addition to this motion, is very important when we injure our wrist. At 2 weeks, I put you into a brace that can be removed so you can wash your hands, and we start working on that wrist motion. Now, there is a caveat to that. Sometimes if people have a really, really bad break that needs that extra stability of a cast for longer, you might need one on for longer. But majority of patients will fall into that category of a splint for 2 weeks. Then you can have a brace that can remove so you can wash your arm and you can start working on that wrist motion. At about 6 to 8 weeks post-op, depending on when you see it and how stable your fracture is and everything like that, that's when we start really cranking up that wrist range of motion and starting that strengthening to get you back to that full 3-month ready to go type of a situation. Benefit of having surgery is going to be this immediate starting range of motion at about that 2 weeks right after surgery, instead of waiting for about 6 to 8 weeks when you'd start range of motion with a non-operatively treated fracture, okay? One really important thing I like to talk about, remember that category of patients that I said was an older population. We call them elderly. It's kind of, it's just our older population. They just have a few more years than our younger population. That type of population that injures their wrist from a fall from standing height is considered a fragility fracture. Meaning, if a young, 15-year-old, 20-year-old, 25-year-old falls, and they fall on their arm, they commonly do not break this bone, okay? They do not get a distal radius bone fracture. If someone that was 20 fell and broke this bone, I'd have to work them up for what's wrong with their bone, because it doesn't happen. Reason being is that our bones are stronger than that. But as we get older, everybody's bones get weaker over time. And that's why you get worked up when you get older by your primary care physician for a possibility of osteoporosis, right? We have these scans, they're called DEXA scans, that look into your bone quality as we get older. It's a routine thing that we do to make sure that our bones are optimized and are at good health for us to support our body and to carry us on through our life. So our bones across the board, and everyone, do get weaker as we get older. And if you break your radius after falling, it's a sign that your bone health isn't great. So in patients that are older that fall from standing height and they break their radius, it's a very important thing that we get you in to evaluate what your bone's quality is. And the best way to do that is with a DEXA scan. Also, plus or minus getting a vitamin D level to see what your vitamin D is like, because vitamin D is good for the bones. And then treatment as indicated, meaning that the results of these things, your vitamin D level, your DEXA scan, what the result is whether it says osteopenia, which is just kind of lower bone mass, versus osteoporosis, which is what we consider a more significant level of poor bone mass. your doctor is going to recommend either just taking some calcium and vitamin D versus possible other prescription medications to try to get your bone health up. So this is really important because I think this is something that sometimes gets missed when people break their wrist, because this is a point that we can intervene and make your bone health better so that you don't get any more breaks in the future. So really important point that I like to talk about. All right, let's talk about the second topic. Second topic is fifth metacarpal neck fracture. Very fancy, okay? I'll break it down for you. Our metacarpal bones are the bones in our hand that are I'll do it this way. Are these bones that are in our hand, not the ones that you think of as your fingers, but they're actually the bones that are in our hand here, okay? And the fifth means it's number 5, right? We have 1, 2, 3, 4, 5. So we're talking about the pinky metacarpal. And that's the bone that's on this side of your hand, okay? And the break right here at the metacarpal neck is what it's called. We don't need to be too technical. But on that image right there, you can see there's the one bone that is bent compared to all the rest at the end of that hand, okay? I didn't put a circle around it, but I did earlier if you saw that. And that break is also known as a boxer's fracture, which is actually a misnomer because professional boxers don't actually get this break. It's usually actually when people that don't usually box or punch things professionally punch stationary objects and they get this break. And so I like to tell my patients when they come in, wherever they punched a wall, they punched, a locker or whatever, that a wall doesn't move and the wall's always going to win. Okay, so try not to punch really hard objects if you're angry or whatever, like punch a pillow or something so you don't injure yourself. So this break, like I said, is not something that boxers get, even though it's called that. We just keep that misnomer. It's actually when the common layperson punches something that does not move typically. I mean, you can get it from punching someone else, but most commonly it's from punching some hard object that's going to win every single time. So don't do it. All right. So when you come in, what are we looking at? So a couple things. We're going to look at your clinical exam. So a big thing that we want to make sure is that you don't have any rotational deformity. We want to make sure that your fingers are pointing in the right direction, all right? We don't want your finger to be pointing, I can't even do it, but you don't want your fingers going this way, and in that picture you see that finger's pointing all the way out that way, right? Your finger's not supposed to be doing that. You also don't want it to be crossing over the other one. So that's important. If you have rotational deformity, we're going to talk to you about surgery, because unless you want to have your finger pointing in an opposite direction, fun party trick, I don't know, it's up to you. But if you want your finger to be pointing in the right direction and it's not, the way to correct that is going to be surgery, okay? So there's one thing, big thing that we're looking at on your exam. We're also going to look about how comfortable you are, how we're able to make a full fist, we're able to straighten our fingers out. Now you'll have pain related to the break, but most people, even with this break, can still straighten their fingers out and make a fist. So those couple things that we're looking at is what our tendons are doing. I don't expect you to have full perfect motion right after you break a bone, right? I'm not trying to torture you, and I don't expect unrealistic things. But we're looking at your motion and we're looking at your rotation. Make sure that it's looking the right direction. You see some of those pictures there are kind of showing, normal versus abnormal. Other thing we're looking at is the X-ray. And on the X-ray, the big thing we're looking at, if you can see there, is how angulated the break is. So I kind of drew a little angle on that X-ray to show you A, where the bone is broken, and B, that angle there showing that it's bent down, okay? So that's what we're looking on your X-ray. That's the most kind of common position for this bone to breaking to go into, is it's going to bend down like that. So we're looking at how much is it bent. Treatment. Well, the majority of these fractures actually heal well. And do you see how I say fractures or broken bone multiply, interchangeably throughout this presentation? It's because they're the same thing. Okay, so majority of these heal without surgery. So they heal very well without surgery. Reason being is that A, this bone likes to heal. Like, remember I said these bones rarely go into non-union. Hand and wrist bones, they like to heal. It's good, yay for bones in the hand and the wrist. Also, the majority of patients, majority of studies that we've done, in medicine, everything's about studying things. Everything's really medicine-based. Evidence-based. So across the board, the way that we're all trained as doctors, whether you do surgery or no surgery or whatever your specialty is, we do things based on doing studies on people to see Do they have better outcomes, like in this situation, with surgery or without surgery? So how we do this is that we have patients that are treated without surgery and with surgery for the same injury, all these other types of characteristics similar, and we see how good they do. Do they do the same? Do they do worse? Do they do better? And for this type of a break, we found overwhelmingly throughout many, many studies over time that whether the bone heals without surgery in a very bent, crooked looking position versus whether they get surgery to make it perfectly straight and they get surgery looking straight, the outcomes are very, very similar in the majority of cases. So that's why the majority of these broken bones, this fifth metacarpal fracture, are going to be treated without surgery, because whether you treat it with surgery or without surgery, if you have the same outcome, why would you go through the risk of having surgery, right? Like infection, the risk of anesthesia, having type of hardware complications of what you put in. So the majority of these get treated without surgery, and they do just as good as if they were to have surgery, right? Functionally, okay? So that's important to know. But not everyone gets treated without surgery. I do the surgery on occasion, not every week. Obviously, like I said, most do without surgery, but I definitely do this surgery. And so it's not in every person gets no surgery. So who gets surgery? Well, one, we already talked about it. If your finger's pointing off in an abnormal, strange position, you want it to be straight again, you need to have surgery to get that fixed, okay? So that's one category that right off the bat gets you a surgery if you want it to look right and function right, because your finger's not supposed to be going off that way. Excessive angulation. So remember how I showed you that X-ray that shows that the bone is bent? I'll go back to it. See how it's bent there? Well, if it's bent a little bit or even upwards of up to 60 to 70 degrees, we've shown that your outcome is very similar. But if it's worse than that, it's like 90 degrees, that's something we might really want to kind of talk to you about, the benefits of getting it straighter so that you have a better outcome in terms of your motion. And sometimes when you have a really bent bone, think about it. If the bone is really bent and is sticking off into your palm here, it's going to be uncomfortable because you're going to feel that bone right in your palm. So if it's really excessively bent, we're going to talk to you about trying to get it straighter so that A, you don't have that bone sticking into your palm and giving you problems when you try to grip things, because we don't want to have that sticking in your palm when you're trying to grip a hammer or doing whatever you're trying to do. And also, you might lose the ability to straighten your finger out just as much as you'd like to. So those kind of, with that bone being that bent, those are kind of reasons why we might recommend surgery. There's that word again, open fractures. So if the bone breaks and it cuts your skin, skip, go straight to surgery, right? We need to, the reason being is that when you break a bone and it opens your skin, you're at risk for infection, right? Because your skin has bacteria all over it. I don't care. I mean, I hand sanitize about 100,000 times today, right? There's still some bacteria. I picked this up though. This probably has bacteria all over it. So think about it. You've got bacteria all over your skin, your bone breaks the skin and then it goes back inside you. Well, it's taking all that bacteria in there with it. So if you have an open, broken bone, you're going to recommend surgery to clean it out and make sure that we don't get a bad infection, right? Multiple fractures. So if all of these bones, go back here, right? If all of those bones in your hands are broken, right, we're going to want to treat them. So if it's not an isolated, just broken bone of this one and all of them are broken, we're going to want to talk to you about surgery, because you need to have some stability in your hand, because that's a sign that you've got really bad soft tissue and bony injury, and you need to have some stability. So we want to get some hardware in there to hold things stable so you heal well. Okay. So what is non-operative treatment? Immobilization. So there's a lot of ways to immobilize you for this type of an injury. And actually, some studies will say that you don't have to actually even immobilize at all. Some studies will have been out there that show that even if you just put an ACE bandage on your hand, the outcome in the long run is similar to if you put a splint or a brace on. Now, I do immobilize my patients when they have this injury because ACE bandage doesn't give you a lot of support, and so you're going to be really painful. And I'm not into torturing people. So I think that giving you some protection with immobilization not only helps your bone to give it stability, but also helps with your comfort. Because I don't know anyone that has a broken bone that just wants to have it kind of free to hit on anything, or anyone can touch you. If you have a splint on, it gives you protection, right? It protects that bone. It gives it a solid, hard exterior. So if you were to hit it on something, it gives you a barrier. If someone were to touch you or anything. It gives you that protection initially as you're really painful and swollen, so that you're a lot more comfortable. So I do like to immobilize, even though outcomes can be similar in some studies showing between even just putting an ACE bandage on it. I think that the protection gives you a lot of comfort, and comfort lets you sleep at night. And sleeping at night is very important. So I do put you in a brace. Now, what type of brace or a cast or splint that you have on can be variable. Some people might put you in what goes onto your fingers like that. That's called an ulnar gutter brace, or cast or splint, whatever you want to put on there. So they might kind of have it come out here. That immobilizes you and protects you here. Something that I've been kind of doing is something similar to that hand-based one. It's actually kind of a cuff. My cast techs will make it. They make it out of casting material, but it's actually something that can come on and off. So you kind of, it holds your hand and gives you the protection, but then you can kind of easily take it off, wash your hand, and then you can put it back on, but it still gives you that mobility that you need in your hand. Because for me, the main thing is when you break a bone, you want to mobilize as little joints as possible. So I don't want you in something too big and bulky that immobilizes things that don't need to be immobilized, because mobility is important to keep you from getting stiff in places that are not broken. But in overwhelmingly, no heavy lifting, pushing, pulling, right? You're going to limit yourself that anyways, because you have a broken bone, right? It hurts. Don't want to be heavy lifting. It's going to hurt more. So you're not going to do that anyways, but no heavy lifting, pushing, pulling for about 4 to 6 weeks before I let you kind of start getting back to the gym if that's what you want to do. Usually immobilization protection is for about 3 to 6 weeks. For me, like I said, it depends on the patient, how comfortable they are, what they're trying to do. I think this removable kind of cast option that's based on the hand is a really good option, just because it allows you to kind of make that decision when you need full-time immobilization versus when you can come out of it and start going intermittent based on your comfort level. So about 3 to 6 weeks of immobilization, then starting to come out of it as you feel more comfortable and starting to get into that more heavy lifting, pushing, pulling activities at about that rate, okay? Expected outcome. So non-operative treatment with malunion. So when you have non-operative treatment, remember, we're not straightening the bone. So if we don't straighten the bone, you're going to get a malunion, right? The bone's not as it was before it broke. But we accept a malunion, and we're accepting it because it gives you a similar functional outcome, right? So if you have non-operative treatment with a malunion, so your bone is bent, what can you expect? Well, one thing is that the prominence of your knuckles, right? So you've got nice little knuckle prominence here. If this bone is bent down a little bit, what you do is you lose that contour of your knuckle. It's mostly a cosmetic thing, not a functional thing, but a cosmetic thing. So you can expect that this knuckle is not going to be very prominent. Second thing, you might have a little bit of an extensor lag at the finger. Now, most of my patients don't have that because the bend is not, when it's bent to like 90 degrees, we talk about surgery, but you might have a slight decreased range of motion. Most of the patients get full range of motion though, I will say. And even if you were uncomfortable, you're like, oh, it's not quite there, you can always do therapy to try to get it as strong and as full as possible. But when I say slight decreased range of motion, I'm not saying anything that is extremely noticeable or functionally a problem. Palpable prominence in the palm, that's what we talked about. Why if it's super bent, that might be really uncomfortable and you're not going to want to feel that prominence. When it's slightly bent, you will have that palpable prominence, but it's not likely to cause you really any discomfort or problems. That's why we accept that. But overall, the main thing about this is to talk about is that you mostly get a good functional outcome with very minimal disability. If we're talking to you about non-operative treatment, even if the bone looks very bent, it's because you're likely to have a very good outcome that is similar to if you didn't, but with those slight caveats. Surgical treatment, very many ways to fix the bone. Fix the bone with some K-wires. Those are those pins that are in those X-rays, some pins that are going this way. You can do pins that go this way. You can do a plate and some screws, or you can do that screw that goes right down the middle of the bone. Very many ways that you can fix the bone. And all of them are very good options, and it'll all depend on, how mobile the break is and how stable the surgeon can get and what their goals are for getting you moving right away after surgery. But all these types of things can happen to fix your bone. Oh, we're on to the next topic. Okay, this is the last topic. It's a finger sprain. Not a really glorious topic. Actually, not very exciting at all. But it's very common. You play basketball, you jammed your finger, or you hit your finger on something, you jammed it. For whatever reason, finger sprains are just very common because, I don't know, there's so many of them, they stick out, they get caught on things. So they like to get sprained, and so we see a lot of it. So where do you get a finger sprain from? Well, sports injury, like I said, jamming your finger, soccer. A work injury could happen. You fall, your finger gets caught on something, it just gets jammed or caught and bent. A car accident or high energy trauma can also happen. A lot of times if it's a car accident or high energy trauma, it gets missed because people are really focused on like their broken femur, which is your leg bone, by the way. Really more important, you really focus your attention there. You miss the small little finger sprain. It's fine, I get it, it's just a finger, but it's very important to me. A sprain is basically a stretch injury to the ligaments around the joint. So it's not a broken bone, so we're not broken or fractured, but we're talking about the supporting structures that give our joints the stability so that they can move and not go off into weird positions. So a sprain is a stretch injury to the ligaments around a joint. Most commonly, it happens at this knuckle right here. It's called the proximal interphalangeal joint. It's this knuckle. So this is like the most common injured sprain joint, and it's a pain in the butt. When you sprain your finger, what you'll get is pain, obviously. It's going to hurt. You get a lot of swelling. Your finger can blow up. I mean, it looks like a marshmallow finger. Huge, very big and swollen. You get very stiff. Why? Because you have a lot of swelling. You have all this fluid. Look at how thin your fingers are. There's not a lot of room for swelling. You get swelling. That swelling just limits your motion right off the bat. It just makes your finger stiff. You don't want to move it. You can't move it. There's all this swelling. There's all this pressure going on. And bruising. So those are just some pictures of some sprained fingers, right? They're swollen, they're bruised, they just look really unhappy. This is what a sprained finger looks like. So evaluation. Now, it is important to have your finger evaluated and get X-rays to make sure that you didn't break the bone, that you just sprained it. Most commonly, people get sprains all the time and they heal them, so they get a sprain again, they jam their finger, something happens, and they're like, oh, it's fine, it's gonna get better. And there's always a chance it's not necessarily just a sprain, because if you break your finger, what does it do? Pain, swelling, bruising. If you sprain your finger, what does it do? Pain, swelling, bruising. So breaking your finger and spraining your finger can have very similar initial symptoms. And if you don't know the difference, why not see a professional that does know the difference and can help you to get better? Because a broken bone might require surgery or might require a specific immobilization versus a finger sprain, which doesn't need surgery and actually does not need immobilization. We actually want to get it moving. So with a finger sprain, your X-rays are going to be negative, so meaning there's nothing broken. Your examination of your fingers is going to be overall very normal. So what we're going to do is I want to examine to make sure that your tendons are working. Your tendons are the things that are powered by muscles that make things move. So your tendons, you have your tendons that bring your fingers down, you have your tendons that bring your fingers up, right? So I'm going to look at those, make sure that those are intact and they're working at every joint in that finger, right? So we want to make sure your tendons are intact. Your ligaments are on the side of the joints that keep the joint from bending like 90 degrees in one direction, right? So your finger, if you notice, doesn't wobble side to side very much, right? Because it's got ligaments on either side that keep it straight so that it just bends and extends instead of bending 90 degrees that way or that way. So we want to make sure that your ligaments are intact. Usually those are intact, but they're injured, meaning they might have a slight, small, partial tear or something, and that's kind of can be related to the sprain complex. But I don't want them to be completely torn and then your finger can bend all the way out. That's not good. So that's what we're looking on. X-rays, making sure nothing's broken, everything's aligned well, making sure you don't have a dislocation. Dislocation is when the joint goes out of place and one bone, bones are supposed to be lined up like this. There's one bone here and there's one bone that's up here, right? That's not good. We don't want that. We need to have these bones in the right position so that they bend and straighten. So your X-rays are going to be looked at to see if you have any broken bones, see if your bones are all aligned in the correct position, okay? Those are normal. Your tendons are normal. Your ligaments are stable. Then we're saying, okay, this is a sprain. So what do we do about it? So to help with the inflammation, elevation, ice, and rest. So elevation meaning you don't want your fingers down on your lap all the time. You want them up, right? It's like a ski hill, everything wants to go downhill. Think of the water going downhill, draining from your finger and trying to go down into your arm. You don't want it here. You don't care if it's up here. Who cares if it's up here? You want it away from the finger. So elevation is good. Ice helps with swelling, so ice is good. And rest from strenuous activity. You're not trying to, don't try to go, lift 100 pounds. You want to you don't want to do some crazy activity. To help with the pain, anti-inflammatories are very good. Anti-inflammatories are NSAIDs, I wrote there. Those NSAIDs, I should have written out, non-steroidal anti-inflammatory drugs. Those are your ibuprofen, your Aleve, your Advil. What they do it's all in the name, they're anti-inflammatories. When your swelling is a reaction, it's inflammation. So anti-inflammatories help with the swelling, so the inflammation, but also help with pain. Tylenol also helps with pain. It's not an anti-inflammatory, but it helps with pain. And edema control, so trying to help with that swelling, with the elevation, the ice, all those things will help with your pain. The less swelling you have, the less pain you're going to have. So you really want to work on that swelling. To combat the stiffness, range of motion. I don't lock you up, you start moving. The immobilization for this is only going to make things worse. Reason being is that it's going to make your joint very stiff. Your joint's already irritated and angry, and then you lock it up, it's going to be hard to get it to go moving again because it's not going to want to move. So typically, you get a sprain, what I start doing is buddy taping. Buddy taping, I should have put a picture, but I didn't, is you strap above and below the joint. So say you injured this ring finger, this joint, right? I'm going to strap it to your middle finger. So I'll put a strap right across here, and I'll put a strap right across here. Why? What is that doing? Well, every time now you move your middle finger, it's going to coach your ring finger to move. Because when you injure your ring finger, you're going to want to do something like this, right? You're going to be like, no, I don't want to bend it. So you're going to leave it up, and then it's going to get stiff and angry and not get better. So if I tape it to your middle finger, I make it so that your ring finger has to start moving. Because to move your middle finger, your ring finger comes along now. That's what buddy taping is. You're buddying it to the middle finger. So when you move your middle finger, your ring finger comes along. It's going to help you combat and kind of mentally get over that whole idea of my finger has to stay straight because it hurts. No. Your finger needs to start bending, and your middle finger is going to help it along. Until you get full range of motion, once your ring finger is coming along and it's doing good and you're moving it and you're happy moving it on your own, you can get rid of the buddy tape, the buddy straps, because the buddy straps are just basically trying to coach your finger to motion. Once your finger is doing that motion, you can continue working on it on your own. You don't need the buddy straps anymore, or buddy tape, or whatever you want. There's straps and there's tape, you can do both. Main thing is, and this is commonly, a lot of times I'll see a finger sprain 2 months after their injury, right? People rarely actually do what I'm telling them and actually come in to see me after they sprain their finger to make sure it's not broken. They show up 2 months later because they say, you know what, I had this injury. I had a lot of pain, swelling, and bruising. The bruising got better, my pain got better, my stiffness is getting better, but look at my finger, it's still so swollen, it looks so fat. I don't know what's going on, and I still don't have it feels really tight, right? That's because it can take months for that swelling to go better. Months, which is why we need to start combating it right away. Right away, we need to start trying to make it better. Because even with right away trying to work on that swelling, it's gonna take months. And I'm talking 3, 4, 5 months. It takes time. And similarly, not to say you're gonna have severe pain and inability to move your finger for 4 months, right? It's just an idea that your finger is not gonna look like the rest of them, and it's gonna take time. And a lot of times when I'm seeing these patients, like I said, they'll be 2 months out from injury, they still have some swelling, it still feels a little stiff, but they're moving it, their pain's gotten better, their bruising's gotten better, but they're wondering, did I do something? Is there something more than just a sprain? And it's a lot of reassurance that I have to do, it's a good thing you saw me, your x-rays are negative, everything's intact, you just need a little more time, it's gonna heal, just give it some time. If you're having difficulty with motion and swelling, then an occupational hand therapist can help improve significantly. If I see you and it's been months and you're really not moving it and you're really scared to move it and all this stuff, hand therapy is great. They kind of force you into getting better, and they work with you really closely and get you that motion that you need because we want our fingers to move right. So that is the end, just going over 3 common injuries. Now, there's obviously a ton of injuries of the hand and wrist that I see, a lot of variability here. But those are just some to go over, and some basic principles about broken bones, about evaluations, about x-rays, about decision making. all these things that can sort of be applied to everything, but specifically kind of use these scenarios to show you what we do and what goes into evaluating you for your hand and wrist injuries. So thank you, and I think we're going to open up to questions. So we'll go from there. So it's pretty broad. Pain obviously can be from anything in your hand, right? So pain could be from a broken bone. Obviously, if you didn't have a break, it could be from a tendonitis, could be from arthritis. So it really depends on what you're talking about. But when people have pain and numbness, numbness is a nerve-related problem. Anytime you feel numbness or tingling, it's a problem with your nerves. And nerves can have issues, multiple diagnoses, but most commonly when people have numbness and tingling and they see us in a clinic, the most common diagnosis is carpal tunnel syndrome. And that is a whole nother topic that we can definitely talk about in a more intimate setting, I think, at a clinic visit, just because it is so broad. But there's a lot that can be done and a lot that we can work on non-operatively, and then if it has to come to it, operatively. But we always start with non-operative treatment and trying to get you better when we can without getting you to the operating room. That's always the goal. But very broad topic, but numbness is related to a nerve problem and does require evaluation, and there are many things that we can do to try to make that better. So definitely get it checked out, see a hand surgeon, maybe me, and we can go from there. So the best way to determine if a joint is out of place in your finger is to get an X-ray. X-rays will show the joints, and they show their relationship to each other. So the best way to do that is to see a doctor and get an X-ray of your finger to make sure that it's in place. Now, an exam, if you know that if you can't move your finger, that's a good sign that something's wrong. Could mean that it's out of place, could not, right? You could have a sprain. We've talked about that, but the best thing to do if you're concerned about your joint being out of place, or the term is dislocated, is to see a doctor and get an X-ray right away. Arthritis, best diagnosed, once again, in the clinical setting on examination and X-ray. So X-rays show arthritis. I actually go over, and I review X-rays with every single one of my patients. So when you come in, you get X-rays, I go over everything about your bones, whether there's a break in it, how to look for arthritis. I'll show you where your arthritis is and how we can see that on an X-ray. So you can see, that's how we look at the joints on X-ray to look for arthritis. Additionally, some people might have an X-ray that shows horrible arthritis and have no symptoms. Some people might have horrible symptoms, but really mild arthritis. So it's a combination between your X-ray and your clinical exam that guides us to, okay, we're treating a problem of arthritis, and how do we deal with this to get you better? Good question. I've actually had to do this recently. So if a boxer fracture does heal on its own and you are unhappy with the outcome, just like with any bone that heals on its own, you can actually correct it. So I've had to deal with, sometimes people show up, for instance, they break a bone, like maybe a boxer's fracture, and they show up 2 months later. Well, remember I told you that bones start healing the minute they're broken. So by 2 months, that bone is like 80% healed, maybe 90% healed. It's very healed. So you can't just bring that, and you're unhappy, right? You can't just bring that to the operating room and, move it around and make it better, right? What you have to do is actually you have to break the bone to then fix it. And it is something that we can do. And it is definitely an option for any type of bone that is treated non-operatively that heals in a position that in the future causes you problems. It's something that we can treat with surgery. It does require re-breaking the bone and then fixing it, but it's something that we do, similar to initially when you broke it and you fix it, you're under anesthesia, your surgeon knows what they're doing, hopefully, and makes you better. So there's definitely surgery that you can do for we call it a painful malunion, so a problem that you're having with the fact that the bone healed in the position that is not ideal for you. So a lot of times I'll work on, active assisted type range of motion, and that's just basically when you're working on any type of motion, specifically wrist flexion. So say you're doing wrist flexion. Say your wrist is like this. This is straight, right? Wrist flexion is this way, okay? So say your wrist only goes to here. You're like, man, that's not good. I don't want that. So what you can do is you can help it, right? So the good thing about your hands, you got two of them. So your one hand can help the other hand, right? So you can work on bending your wrist down, right? Going like this, and then taking your other hand and guiding it and helping it. The one thing I like to show all of my patients is that improving motion isn't about a this thing. What are you doing here? Nothing. What are you doing here? Nothing. You're not improving your motion. When you're trying to get better motion, it's all about stretching. If you think about ever in your life, when's the last time you stretched? I have no idea the last time I stretched. I am completely out of shape. But if you think about stretching, you did it at some point in your life, right? Maybe recently, maybe a long time ago. But when you stretch, you go to a position and you hold it. You're trying to improve motion by stretching it, right? You're trying to hold that position. So if you're trying to do wrist motion and you're going like this, you're like, oh, it's not getting any better. Well, what you're doing is you're just moving in your comfort zone right now. You're not testing it. You're not stretching it, right? So you want to go from this, you want to bend it down, get it as far as you can, use your other hand, try to get it further. You'll feel the pull, right? And I like to tell people, you don't want to push it to the point where you're crying. Nobody wants to see you cry. Don't start getting, don't go from this and go and yank on it and scream and go, oh my God, why'd she tell me to do this? What you want to do is you want to get to the point where you feel a little bit of discomfort because you want to push the limits of your norm, what you feel comfortable with. So you want to push it there and you want to get it right to that level of, this is a little uncomfortable, but it's okay, and hold it there. And I say, count to 10. Once you're done with 10, then relax, okay? Let it go. See how you're doing. Then come back to it. Bring your wrist down. Bring your other hand. Try to push it a little bit further. Hold it. It's a stretch, right? And then relax. A few times a day, doing that repetitively. You can use weighted things to help you too, right? If you hold something heavy and you dangle it, especially wrist flexion, I can't really show it here, but you have a surface and you want to get more wrist flexion, right? Hold the weight in your wrist, right? Weight in your hand. Drop it off the end of the table, right? That weight is going to try to pull your wrist into flexion, right? So we're trying to stretch things. We're not trying to do one of these. Because this happens a lot of time with my finger stiffness. Oh, I've been working on my finger motion. Like, you're getting nowhere, right? You need to get it there and you need to give it a little hug, push it, hold it, stretch it. So wrist cysts, very common as well. Most commonly, they're a benign ganglion cyst. You'll hear that word, ganglion. Most commonly, they occur on either the back of the wrist or they occur kind of right here. Options for treatment, well, if you talk to, your aunt, your uncle, your grandma, whatever, they might say, hit it with Bible, right? It was like, back in the day, it was like the Bible, what do they call it? It's Bible squashing, whatever you do. Because they say, if you have a big bump, hit it with a hard heavy book, and make it go away. So, okay, you could do that. I'm not going to do that to you. That's probably abuse in a clinical setting. I can't hit you with a book. So I'm not going to do that. But, a lot of these cysts, might go away. What commonly happens is a patient actually comes in and they said, yeah, I had this cyst, this bump, and then I fell and I hit my arm against the wall and it went away. So they can go away like that. They can go away on their own. Actually, in pediatric populations, the majority of them, so in kids, when they have a cyst like this, the majority of them, over 75% of them, actually resolve within a year. In adults, we're not that lucky. So if you're an adult, not going to happen as commonly. But if it gets hit and it can go away, it can rupture, right? Another option, if it's on the back of the wrist, I don't really do it for this area because it's right near a really important artery. But on the back of the wrist, I can stick a needle in it and pull the fluid out and hope that it goes away. Now, you have about a 50% recurrence rate with that. So it may make it go away. It may not. It might come back. I mean, it'll go away for the time being, but it could always come back. And then lastly, the best way to get it to go away and know that it's going to go away, the most sure way of getting it to go away for good, but still has a risk of recurrence, so it still could come back, is actually surgery to remove it. So there are a few different things, or you could do nothing. If it doesn't hurt you and it's benign, so meaning it's not like a bad cancer, then you don't have to do anything about it. So you can do nothing, hit it with a book maybe, or I can pull fluid out of it in the clinic, done that recently. It'll definitely make it go away temporarily, might come back, don't know, you're taking a gamble, but worth it it's pretty quick. And then also surgery, right, so we can remove it. So injections, very common. We use them a lot of places in the hand and wrist. We use them for tendonitis problems, for nerve problems, for arthritis problems, so a lot of different ones. Now, in certain areas, there are definitely limits. So if I'm gonna put any type of an injection near a tendon, I'm going to limit it to 2 injections. Arthritis, if you have a really bad, severe arthritis in a joint, a lot of times, you know, I'm gonna talk to you about it, right? So I'm not gonna really put a limit on it, because injection into a joint that's really badly arthritic is going to have very little detrimental effects, because the joint's already it's already not doing so great. So, right, if I keep injecting it, it's not really going to cause you any problems. Like, it's not going to make your problem worse. Your problem's already pretty bad, probably. So I can do them multiple times. I like to talk to people about it, though. Like, if I do an injection and you get 1 week of relief and then it's back again and you wait another 3 months and you get another injection, am I really helping you? That's the question. Are you really getting what you need out of it? Because if you're not, like if I see a patient that's really not responding to them or needing them very frequently, then I really want to have a conversation with you about surgery, because there is a really good surgery for this problem in the right patient. So the patient that's been having all this pain and had multiple injections and it's not getting better, you know, I'm going to try to start talking to you more about surgery. But is there a specific limit for injecting the base of the thumb? For me, no. Okay, but we've got to think about, am I making you better? I like to make people better, and doing multiple injections that are only lasting a short period of time aren't really doing that. Risks of injection are always infection too. So anytime you poke skin, anytime you cut skin, you give blood, you do anything, anytime skin barrier is broken, there's a risk for infection. So there's always that risk that you have to worry about with an injection. But the actual damage to the joint, if the joint is really bad, you're not really doing anything further to it. So there's not too many other risks. It's just basically that risk of infection and the risk of my sadness of not making you better.